All right. Good afternoon, our fellow participants. Thank you for your patience. Right away, we'll be starting our meeting. I am Dr. Akafa Tensaba. I am together with my colleague,
Dr. Jonathan Idoko.
So today, we shall be considering viral hepatitis C and viral hepatitis B, and we'll be looking at clinical review and management in the course of this discussion. So this is the background we're going to be having our discussion on. We'll look at the burden of the disease, hepatitis B burden, and we'll also look at hepatitis B divided into type A and B, which is acute hepatitis B and chronic hepatitis B. We're going to also look at how people acquired hepatitis B, and we'll take some guidelines, mainly considering the serological markers and their significance. We'll make an attempt to define what chronic hepatitis B is. We'll look at key recommendations from various authorities across the world, within and abroad. And then we'll take the endpoints of the treatment and consider some preventions that are needed to control the spread of hepatitis B. And I'm sure that a lot of us are already considering and wondering, why haven't we gotten a cure in respect of hepatitis B? In this discussion, we'll be looking at the reason why we've not been able to get a significant sterilized cure, and then challenge ourselves on the way forward. What is hepatitis? Commonly, it is nothing but inflammation of the liver, and it is caused by so many agents, toxins, chemical infections, and so on. Hepatitis B, as you all know, it is a preventable viral disease caused by the virus hepatitis B. And regarding the burden of the disease globally, it's been known that about 1/3 of the population of the world is affected by the burden of hepatitis B, about 2 million thereabout. And then eventually those that are infected may progress to chronic hepatitis B, and worldwide, about 250 million chronic cases have been identified. And also about 686,000 deaths related to this disease have been known. So you can compare it with the situation we have at hand now, which is coronavirus, and you can agree with me that the total death toll from hepatitis B far exceeds that of corona. So that is to say that the effort we are putting into corona, we should do the same with hepatitis B. Let's just look at the situation here within the country, Nigeria. About 200 million population have been estimated, so to say, from the total population in Nigeria. Then let's look at it. How many people have been infected with the virus and have turned out to have the surface antigen positivity? It takes about 10 to 20%. That's from out of this 200 million population, about 15 to 30 million have been, from studies, discovered to have surface antigen positivity. And then progressively from there, about 220 million are carriers of the infection. And within annual burden, death toll from hepatitis B in Nigeria is about 200,000. Compared to coronavirus death toll, you can Google and see that it's not even up to the infected body of coronavirus is far from this value. It's about 167, there are about 1,000 as of today. So we can go to say that the effort we're putting in again on on coronavirus, we should do the same in order to try to control or curtail the spread of the virus in Nigeria. Let it be known to all of us that any blood fluids that an infected person produces is likely to contain the virus, depending on the concentration. Sorry, we'll look at somebody commenting or somebody is asking a question. Okay. If you're having difficulty, you can call us so that we'll reach out to you. There is a bad news regarding the disease, which we're going to mention to us today, so that we'll be conversant to know that hepatitis B virus is 100 times more infectious than HIV. And it can survive outside the body as long as 7 days thereabout than even HIV. And the third bad news is that it is the second most important carcinogenic particle known worldwide. And it can progress to cirrhosis, it can cause liver failure, and it can cause liver cancer. So chronic hepatitis B is what we're going to deal with or dwell more on today. It often produces symptoms. It doesn't produce symptoms until liver is severely damaged in terms of fulminant cases, in terms of failure of the liver, and in terms of decompensated cirrhosis, and even in the case of liver cirrhosis, liver cancer. That's when you begin to have some symptoms appearing.
No, sorry. I think we're going ahead too fast. Is it possible? Let's try and differentiate between acute hepatitis and chronic hepatitis.
Okay, acute hepatitis is when an individual is infected with the viral particle and the duration is 6 months and below, and you are able to identify the viral particle, which is called the surface antigen positivity, after you have done a serologic test. And then the most important antibody that will help you define acute viral hepatitis is IgM. IgM will help you to distinguish whether it is an acute condition or the chronic type. And by the time you begin to see the presence of IgG appearing in the serum, that goes to say that it has exceeded 6 months. And so you call it chronic viral hepatitis. That is a simple way to put it.
So you mean, sir, that you have the surface antigen, hepatitis B surface antigen
is positive.
Is positive and stays beyond 6 months.
Is positive. It is not the marker for acute only. It can be present in chronic too. Positivity of the surface antigen SBAHG in acute state and in chronic state. But the distinguishing factor is the marker that we call IgM and IgG. These are the two markers. When they begin to appear, you now said, if it is just IgM that you see in the serum, at that stage, it is acute hepatitis B. But if you see the presence of IgG, because IgG normally appears much later, IgM appears earlier. So IgG appears much later. So when you begin to see appearance of IgG at that time, it is chronic hepatitis. Any other question from the participants? We are not getting questions yet.
Let's go on.
Okay. So far so good. We have been able to, but we'll see more of that as we progress to clarify. Somebody is raising a hand. Yeah.
Please go on. Those who have raised their hands, can you ask your questions by chat, please? Thank you.
You can put up your question in the chat box, please. Sorry.
No, it's not. The slide is not moving.
Next slide. Next slide. Click on it. All right.
Sorry about that.
We're having a little technical hitches here. Please, we'll come back to you. Sorry. Talked about this. Let's go on. All right, we will be looking at, because it is important in treatment and in trying to find out whether the disease is acute or chronic, you need to understand the microbiology of this very virus. You can just imagine that you have 3 structure or cycle in your brain. The first one should be the envelope, because hepatitis B virus is an envelope virus. And the envelope is in the center. So picture another second cycle in the center of the first cycle you have drawn. The first cycle is the surface antigen. Then the second cycle you're going to draw in your brain is the enveloped antigen. Then the core, which is the center thick cycle, which contains the DNA itself and the genetic particle, should be considered as the core. So we have 3 antigens that we are going to look at. Each of these antigens have their corresponding antibodies. So when the virus invades its host cell, what it does, it tries to release its DNA, and the DNA incorporates on the cell host to form what we call a particle that they bond together. And then in that relationship, they begin to multiply further. We'll see that shortly. And when that happens, the immune system make an attempt via the signal that is sent to it to come for the foreign body that has invaded the particular cell.
So no, you mean we're talking of the hepatocyte now, that's the liver cell.
Liver cell and the antigen that has invaded the normal hepatocyte. So that is the first thing that the virus do. when the virus invades the body. Once the virus invades the body, it tries to take over the mechanism of that particular cell and to control it. That's what the virus do. A similar way that HIV, yes,
it takes function of the hepatocyte.
Yes, it takes over the function of the
hepatocyte.
Yes, hepatocyte. So by the time it takes over the function, it tries to go into a kind of factory, let me use that word, to produce its own kind and keep replicating and transforming in similar way like the HIV does. Still on the virology, we just want to refresh our brain that it is a partially double-stranded DNA virus. And you could see that most of the lab reports that come to us in terms of log value and so on. Today, we're going to look at the meaning of log 10 or 10 to log this or 10 to power this. Usually, the virus multiply in millions. So it will be difficult for us to write the numbers in a figure of 5,000 or so. And that is why it is written in log value as the report comes to us as physicians from the lab. So usually once a virus infects, generally in a day about 10 to power 11 to thereabout power 13 is formed or produced in the infected person per day. So you can imagine that kind of multiplication, and then it will now begin to cause inflammation, and in the process of time, it will cause fibrosis or what we call cirrhosis, and then lead to some other consequence. But at this point, I must draw attention that the virus itself does not cause cytopathology. The virus itself is not cytopathogenic. The problems that come as a result of, or the consequence of the disease is from the response that come from the immune system or the host immune system. We shall be seeing that in a short while. So we'll look at the transmission. How can individual get it? Just to make it simple, can be vertical, can be horizontal. Vertical, mother to child, and then horizontal between colleagues, between friends, between partners, and then between infected surfaces. These are most of the ways that it can be acquired. 90% of infected infants become chronically infected because of one, their immune system is not well developed. They acquired it transplacentally from mother to child. And then between person to person, we call it horizontal. So about 20 to 50% of people infected in the early childhood also become chronically infected. But only few adults that acquire the infection, which their immune system is able to withstand, they are able to overpower the virus, so to say. So majorly, recipients, child to child, it's the most common mode of transmission in Africa. Contaminated needle, use of contaminated needles, sexual contacts, and then healthcare workers, and then from blood transfusion. These are some of the common way to acquire the virus. We had a question from somebody: what does the presence of E or C antigen or antibody connote in terms of infectivity? Okay, in terms of infectivity, as I earlier mentioned, that the virus has three antigens. The hepatitis B surface antigen represented by letter S, hepatitis E surface antigen represented by E, and hepatitis B core antigen represented by letter C. all of these have their corresponding antibody. So when one begins to see the presence of the E antigen, it shows replication and it shows infectivity. High infectivity. But by the time you are having to see an antibody against the E antigen, it shows low infectivity. That is the implication. Low infectivity, because the body is able to produce antibody that will mop up the E antigen. Then when you begin to see the antibody to C or core antigen, usually the antigen that are produced from the C or the core region is mainly titled or named C antigen. So two types are produced against the C antigen called IgG and IgM. IgG begins to appear much later than IgM. The presence of IgG signifies chronicity, and then the presence of IgM signifies an acute state. This is just the simple way to classify it. So summarily, in terms of infectivity is very high when the E antigen begins to appear. Thank you. You can seek for more clarification as we go on. Okay. Sorry, we're having a little technical hitch here. Okay. We're going to look at the risk factors now in detail. Practices, lifestyles, people's behavior, the common way by which the virus can be acquired. Most commonly, transfusion of infected blood from commercial donors, especially when the blood are not screened, and then infant born to hepatitis B surface positivity and hepatitis E antigen positive mothers. So high risk factors of acquiring the infection from mother to child, and then use of unsterilized or contaminated sharps among people that practice scarification, tattooing, hair piercings, circumcisions too, manicures, and so on. So some of these are the risk factors that lead to acquisition of the virus. And then people that practice ovulectomy from untrained people, especially medical quacks. In the north, we call them people that do wanzami, and they practice belly and so on. It's very common practice in northern part of the country. These are risk factors because those instruments are not sterilized and those people are not trained. Intravenous drugs abuse is a lifestyle-related way of acquiring, and then commercial sex workers and so on. These are all the risk factors via which the virus can be acquired. Now, I have mentioned earlier that the body fluids of infected individuals carry the viral particle. And then people begin to ask questions, does feces contain the virus? Does urine contain the virus? Does semen and vaginal fluid, saliva, and so on contain the virus?
So there's a question here.
Okay.
The second question here is, please, which of the markers is commonly used during screening as a potential blood donor, and what is the implication of a positive result during screening?
Yes, the easiest and the cheapest available method available to us for blood screening is the surface antigen, because that is the one that normally appear first. Is the one that appear first and is the one to disappear last. So that is the marker we use in terms of blood screening. And once donors presents with a positive surface antigen, we don't allow them to donate. We send them to their physicians to monitor them. We'll see that in detail shortly, how to manage acute hepatitis B and how to manage chronic hepatitis B, and then how to follow them up. So once we have gotten somebody from the lab as a donor of blood that is hepatitis B surface antigen positivity, we counsel the person and we encourage the person to see the physician, and the physician continue to monitor the person and do the other workup that are readily available for the individual to benefit. So, as I said before, the body fluids have various concentration of the virus. Blood, serum, and wound exudates have been known to have higher concentration compared to sweat, feces, urine, tears, and breast milk, who had the lowest concentration. In fact, sometimes you cannot even have a detectable viral particle against the hepatitis B. But let it be known that hepatitis B is not transmitted through breastfeeding or other fluids because of the low concentration. And it's been known also that there is no identification of the virus in feces.
Please, I can see two people are still raising their hands. If you have any questions, can you ask them through using the chat box, please? We'll take all your questions.
Please ask your question through the chat box. We'll read it out and then we'll attend to it. All right. From the questions we have been receiving, this is the point to make a more further clarification on the serologic profiles of people with hepatitis B infection, how they can progress. Once an individual is infected and we identify hepatitis B surface antigen, and then we also identify or isolate the IgM, that's antibody to the core. Because once the body notices the presence of the foreign viral particle in the cell, what the body does, the body goes for the core. The body goes right, the immune system goes to capture the core machinery of the virus. And that is why you will see the appearance of IgM and IgG before the other antibodies will begin to increase in their concentration. So once from this graph, if you're seeing it, when an individual is infected, just to take the natural history or the natural course of progression, between 0 to 4 weeks thereabout, you begin to notice the concentration or the titer of the hepatitis B surface antigen begin to increase sharply from about 2 weeks to 8 weeks thereabout to 12 weeks. And that is the duration that is considered as an acute condition, between that thereabout. And as that concentration, as the titer is rising, the body immune response begin to form an antibody against the core antigen, straight up, just to try to curtail the replication of the virus within the cell. That is what goes on. The total antibody core appears, the IgM also appears and starts increasing in concentration. Using this graph, I think you can just understand. So, and then the hepatitis B envelope antigen remains steady because it is a marker for replication and it continues into a time of chronicity. And then the antibody against it begin to form later. If the antibody begins to form, that is an indication that in terms of infectivity, it becomes lower than when the anti-HB is absent. This is just to tell us in more detail that hepatitis B, chronic hepatitis B is what we're going to consider mainly now, is a silent disease. And mostly the early phase of it is asymptomatic.
So, sir, you mean after the acute phase is over?
After the acute phase is over,
when the chronic phase begins, the symptoms would have subsided if there were any at all at the beginning.
Yes, if the immune system is able to handle the situation, because the acute viral hepatitis state, it can either resolve or it can progress, or it can remain undetectable. It can either progress to chronic state or it can resolve. Yes. And the third one is the virus will be there and the immune system is able to surmount it. But later it can become reactivated again and continue as a chronic viral infection. That's how it goes. So mainly we diagnose hepatitis B by the viral serological markers commonly, which I have mentioned earlier, which we use the 3 antigens and the 3 antibodies. But I want to just draw attention that the core antigen does not appear because it is deeply buried within the particle of the virus. And that's why when we order for 5-in-1 serological markers, we don't normally see a result from hepatitis B core antigen being reported. What are the predictions that you can use to predict whether the disease will progress? Somebody that use alcohol, and then the presence of aflatoxin exposure, especially aflatoxin B, and then people that take cigarettes, cigarette smoker, and those above the age of 45, especially men, people with family history of primary liver cell carcinoma. Also, you can predict that they can have progression in chronic hepatitis B disease. Co-infected individuals, either hepatitis D co-infection or HIV infected individuals. These are all markers of progression, including people with diabetes and obesity. And those that have hepatitis B virus, the genotype C, because we have genotype A to E thereabout. So those that have the C genotype are also can be used for prediction of chronic disease. How can we define chronic hepatitis B? If we're asked to define what chronic hepatitis B, usually we use duration, and then we use the serology markers to define chronic hepatitis B. The diagnostic criteria here that we use is the appearance first of the hepatitis B surface antigen positivity. And then when you do the serology marker and you begin to see the presence of co-antibody, either IgM or IgG, especially IgG specifically, and then even if there is no antibody against hepatitis B surface antigen, that is a chronic hepatitis B. When you have a serum DNA of the virus, usually we say viral load. When you have a viral load that is greater than 20,000 international units per mil. Are we having another question?
Yes, I think a question from Mrs. Dr. Hadiza Idris.
Okay.
What is the concentration of the virus
in LICO? The concentration of the virus in the LICO.
I think I can answer that.
Okay.
It hardly crosses into the LICO. Okay, hepatitis B is gotten by vertical transmission through when the baby is passing through the birth canal. That is where it is possible for the baby's blood to, for the baby to, the secretions from the mother's birth canal to the baby for her to inhale and probably swallow. That is where it's possible to contact it. I believe that it is very low in life.
Okay. Do you
have any contrary?
How the child or the baby contacts the virus is through exchange of blood and blood products during the birthing process. That's the major way. If not, it's not been well established that the virus is found in LICO. So as I was saying regarding the defining criteria for chronic hepatitis B, the second method we can use is to measure the viral load. Once the viral load is above 20,000 international units per mil, which is 10 raised to the power 4 to 10 raised to the power 5 copies per mil, we have a conversion that you can use. You can use either copies per mil or international unit per mil. The WHO have given us a standard method of calculating it. Just multiply it by 6.5 if you want to convert IU per mil to copies per mil. That's just a simple way of getting it or getting around it.
Sorry, there's a question from Sandra Ibeneme here. Good afternoon, sirs. She writes, I read that there is a variant of hepatitis B virus that is already E antigen negative. I need some clarification on this. Thank you.
That seriously is a mutation. There are various mutations of the virus that are currently found. So if you see that, it's likely a mutated type of the E antigen. That's just the simple way to put it.
I think we answer this properly when we go further. We'll discuss about mutations.
Yes. So persistent or intermittent elevation of the specific liver enzymes. When there is an injury to the enzyme, to the hepatocytes, the liver enzymes appear elevated. So at that stage, we'll also see ALT, which is the specific liver enzymes, rises intermittently or persistently. You can classify that as a chronic disease. And then if you do liver biopsy, of course, which is the final or the best option to do, you can definitely say that it is a chronic hepatitis. This is just a picture to further buttress on that. I've explained this earlier, that the whole marker of the infection is hepatitis B surface antigen, just to summarize on the serology marker, because most people that go in for postgraduate exams or one form of both exams or the other, they encounter this, and normally it's a problem for them to be able to answer their questions rightly.
So you just describe the virus again for clarification.
So just to summarize again, that the picture you're seeing in front of us is considered to be the virus material, which here is the cycle that I was describing earlier, that you draw the first cycle with the surface marker, which is called hepatitis B surface antigen. You see them here, like this, surrounding the virus and forming like a capsule around it. So it is the whole mark of the infection. And that is what we use to screen people when they come to donate blood, and is the first marker to be used for diagnosing hepatitis. So it is a major tool, as I said, for screening and diagnosis of chronic hepatitis B if it persists beyond 6 months. Then another marker that is of interest to us, though this antibody to hepatitis B surface antigen appears a little later than the core antibody, but I just want to bring them close so that we'll know the relationship between them, that this is the which is an antibody against the surface antigen, which is this blue Y that you see here. It comes to coupled to the surface antigen. So what's the use? It's a marker of immunity. That's a simple way for those that went for exam. It is a marker of immunity to hepatitis B, and it's only detectable, and is the only detectable marker for successful immunization. So if you see just this in your screening test, it shows that the individual have been vaccinated. And you don't see this, you don't see other particle. It shows that the individual have been fully immunized.
So, sorry, doctor, before we go further, the hepatitis B surface antibody, is it a regular test in the lab that will tell us that yes, this person has been immunized?
Yes, it's the regular test that you just ask for serology, viral serology against hepatitis B infection. Okay. So once you don't see any other particle, either hepatitis B surface antigen and the other ones, that means the individual receives or have this from vaccination, because this is the material for vaccination. The core antibody is the one that, among the three antibodies, this is the first that appears among the antibodies to the other antigens. This is the one that, because once the body system realizes that there's a foreign particle, a foreign material, it goes for the core part of the virus, and that is called anti-HBC. So what is the use of anti-HBC? Anti-HBC is a marker of previous exposure. If it is IgM that appears, it's a marker of recent infection. But if it is IgG that appears, it's a marker of, yes, chronicity. Just remember, this is a virological particle, and the way we measure it is to request for a viral load. We commonly call it VL, which indicates an ongoing viral replication. And it is the most important marker for infectivity and risk for major liver disease. Hepatitis E antigen is a marker of risk for transmission, infectivity, and so on. That's a summary of the serology markers. Somebody is making a comment.
There is no mention on Emmanuel. The question he is asking is, what is the marker for natural immunity by vaccination? Thanks.
Okay, I think
I think we just answered
yes,
that.
we just answered that. Maybe when we go further, we'll see that again. Just follow up, please.
We'll answer
repeat
your
that.
question later.
Yes.
Please, I thought the only defining criteria for chronic hepatitis B is hepatitis B surface antigen positivity longer than 6 months.
Yes, that's one criteria.
In acute hepatitis B, the viral load is also elevated.
The viral load is also elevated. Yes, it's possible. And it's also elevated in chronic state. So it is not the only marker to define chronicity. The markers for chronicity I have listed earlier before. Can we go back? Oh,
Of course.
maybe we'll go back so that you just have a look. This is the defining criteria: the presence of hepatitis B surface antigen for more than 6 months, or the presence of hepatitis B surface antigen together with the core antibodies, specifically IgG, with no antibody against the surface antigen. That is also a criteria to diagnose chronicity or chronic viral hepatitis. And when the serum level or the viral load of hepatitis B is above or equals to 20,000 international units. These are recommendations from WHO and European Association for the Study of Liver. They are well-known authorities, and these are the recommendations for diagnosing chronic viral hepatitis using these references, or the presence of persistently or intermittently elevated ALT.
Okay.
Or when one does a liver biopsy, it can show chronic viral hepatitis B. I think that answered the question. These I've explained before. We explained this before. I've explained this. I have explained earlier, just to recap again, the World Health Organization have standardized the unit to measure hepatitis B viral components, either using the international unit per mil or the copies per mil. The copies per mil, once you know the value, if you want to convert to international unit per mil, you just divide by 5.6. And that is all. Some people approximate it to 6. And that will not confuse you. So undetected viral load, fewer than a lab can identify, generally less than this, they call it undetected viral load. Some reports will come to you as a physician in your consulting room, undetected viral load. Usually, their equipment is not able to detect the viral copies below 200 or 300 copies thereabout. That, if you divide this 300 by 5.6, you're going to have it back to international unit per mil. This is still the question we have been dealing with from the beginning. The significance, the marker, what does it mean when you have hepatitis B antigen is an infection? It can be chronic or it can be acute. When you have the E antibody, or the E antigen, it shows a sign of infectivity,
High
infectivity, yes, and so on. This is just repetition. And then for those that go for exams, this is just to help you remember that when you have a screening test done for the serological markers and their virus interpretation, when you have the surface antigen, there's this, sorry, I missed out something. Supposed to. I think I've explained this clearly initially. But I wanted to answer the question of one of my sisters that was promised her that this slide can answer it. When you have the surface antigen positive, and then the antibody negative, and then the core positive, is either acute or chronic. The core can be IgG or IgM. When it is IgM that is present, the interpretation is acute viral hepatitis. That's how you define it. And what is the recommendation? The patient should go for further evaluation and testing. If you have this and this positive, that means IgM is positive and the surface antigen is positive. The person is acutely infected. But if you have the IgG rather, present with the surface antigen, the person is chronically infected. So the recommendation is you send the person for further evaluation, and then the person begin to do other tests. Now, to answer the question of somebody that was asking whether natural or this is the table that clarifies that. And once you have surface antigen negative, and then surface antibody positive, and then the co-antibody is present, it shows that the person had previous infection, or the person have infection but presently had developed immunity from previous infection. So what you do for that person is to follow up the person appropriately. You don't discharge that kind of patient away. And when you have the antibody to surface antigen only positive, I've repeated this before just to remind us, is that the person has that particular material from vaccination. And the recommendation is that there won't be further evaluation or action. If all the three are negative, the patient is at risk. That means the person is not having the infection. Yes. That means surface antigen is negative, core antibody is negative, and then surface antigen is negative. In that, the recommendation is you send the person from your clinic for vaccination.
So that means that when a patient comes for hepatitis B screening,
yes,
what you get is all these
serological markers or biomarkers,
all negative.
Yes.
You can advise the person to go for vaccination.
Vaccination, which is the key way of prevention. Okay, one of our colleagues, Dr. Nico Osaji, is commenting that the vertical transmission of hepatitis B is also transplacental in addition to other means. This is largely depends on the viral load. Patient can be investigated by carrying out the 5-in-1 panel tests that we mentioned earlier. The viral load and the arrangement of liver function tests will determine the commencement of tenofovir antenatally. So that goes to say that women who are pregnant can take tenofovir during pregnancy.
Who are positive.
Who are positive, yes.
Thank you.
Thank you, Dr. Nico, for that comment.
For that comment.
Additional comment.
Yes. Okay, there's Dr. K.K. Ezra and Debo. Please, how can I differentiate between immunity against hepatitis B from immunization and natural acquisition?
This we have answered.
We have answered. Once you are immunized, you have antibody against hepatitis B surface antigen.
Yes.
Once it is present in your serum,
yes,
it means you have been immunized.
Yes.
Even if you have been exposed to hepatitis B infection, and all that is seen after that, the test is showing that you have antibody to hepatitis B surface antigen, it means that you have immunity. Your immunity can be acquired from either vaccination or from prior exposure to the virus.
Correct. And the presence of the surface antigen goes to show that the acquisition of the antibody is,
From infection.
yes, from infection and not immunization.
Okay. Kadri Bamindele Ibrahim is asking, is there a prodromal period for hepatitis B surface antigen? That's one question. The second question is, if a patient is transfused with hepatitis B surface antigen negative blood, can the patient become positive after 6 to 8 weeks?
Yes and no. For the second question, there's what we called the window period, when one is screened for blood during blood donor, the commercial donor, whosoever comes for blood during blood transfusion. When they come, some of them might be in window period, and when you do the test, it might be negative
At the time of the test.
at the time of the test screening. So that is why I say yes or no. The disease can be reactivated from acquired symptom of occult disease.
Yeah, or
Yes,
window period.
or window period. So these are possible ways. So you can possibly have this kind of case. Is there a prodromal period for it? Prodromal symptoms are there, yes. Which is prodromal, the symptoms are usually like constitutional symptoms.
Symptoms like any other febrile illness.
Yes, any other febrile
You have
illness.
weakness, headache, loss of appetite, body pains,
Body
vomiting,
pains.
and so on.
Yes,
So it's not, there is no particular differentiation between the period, the initial period of infectivity and any other febrile illness per se.
All right. Oh, we're answering the question. Okay, is there another question?
Yeah, there is, I don't know, I can't.
Okay, in our clinics, we mostly do surface antigen only. So how can we differentiate without further markers done? Okay, just to help to answer some of these questions, is just the cost of care is very important here. When you know that the purpose for the presentation is either for blood donor, you can't say the individual should go and do all the serology markers. The first thing that we said was that the hepatitis B surface antigen appears in the blood. So once you are able to identify that in a serum, there's no need to allow that person to donate. But if you're just doing general workup or screening for somebody, you can't ask for further things. One, the person is positive. If the person is negative, you can allow the person to come back after 2 to 3 months for follow-up and repeat the test. And once you identified, your concern is to establish that the person have the infection.
Or doesn't have.
Or doesn't have,
as
the case might be. That is your concern at the clinic. Because somebody that is healthy and is not having any symptoms, he just come, and because of the cost of care, you want him to do all the tests, and then it turns out to become negative. But the simple method to use is the surface antigen first. Once it's positive, you can now request for other markers.
Okay. So I think what he is asking,
yes,
he said they mostly they do hepatitis B surface antigen only. So how can they differentiate without further markers done? I think that once the person is positive, in order for you to be able to advise the person further, they need to still go for full screening, which involves the 5 panels, liver function test, liver function test, the panel,
and the viral load.
And the viral load. Yeah, I think it's part of the 5 panel. Viral load is part of the 5 panel. Okay. If you want to really help the person, as long as the person is positive, is have a hepatitis B surface antigen positive, you still need to go further and check all this, and also to scan the liver, which also gives us an idea, depending on how long the person has had the infection, whether if it is chronic. We're able to see some features on the liver from scan to tell us how bad it is. If we go ahead and give a vaccine, that's the second part of his question, to previous infections, is there an adverse reaction?
Now, to think about it, what's the use of vaccination? When somebody is already infected,
immunized, as it were,
as
from infection.
The person is infected, the person will have the capacity to develop the antibodies to the hepatitis B surface antigen. Yeah. So it's waste of resources.
Well, once you have you have screened the person, okay, and the person, of course, said that he'd been exposed to hepatitis B surface, infection before. Depending on the result of your test, if the person is still showing hepatitis B surface antigen positivity, there is no point immunizing the person because most likely the person is in a chronic state. But if the person is negative and the person has had the infection before, it means that the person is immunized via the infection and there is no need for any vaccination. But usually, even if the person is surface antigen positive, immunizing the person is of no use. One. Number two, there is really no adverse reaction to the vaccine because of that.
All right, thank you. Any other question? Okay, that's all.
Okay, let me see. Okay, this is the last question. So go on.
All right. Okay. So recently, some authorities are beginning to develop some nomenclatures that are used to define chronic hepatitis B in terms of classifying them into phases. They use still the serologic markers and the viral load and then the liver function test to put all of that together from phase 1 to phase 5. And the American Association for the Study of Liver Diseases recommends this classification, and the European Association for the Study of Liver also had this nomenclature coming up. I just put it up here so that we'll be aware that such nomenclature exists currently, and then their old terminology. Now, in phase 1 of the chronic viral infection, you will notice that the surface antigen will be high, the E antigen will be positive, and then the viral load will be above 10 raised to power 7 international unit per mil. The liver function tests, ALT specifically, may be normal, and then there will not be sign of any, or there will be minimal affectation of the liver. The old terminology that we're familiar with is called immunotolerant, if you see all of these parameters appearing. And then phase 2, the hepatitis B surface antigen will be high or intermediate, and then the E antigen will be positive. Then you have a range of the viral load between 10 raised to power 4 to 10 raised to power 7 international unit per mil. And then when the liver enzyme is raised and there is moderate or severe liver disease, the person becomes, using the old terminology, the person is in phase 2 of the new terminology. And then the old terminology will call it immune reactive hepatitis B positive. And then in phase 3, the old terminology is called inactive carrier. In that state, the E antigen will be negative, the viral load will be low, the liver function will be normal, and then there won't be evidence of liver disease. And then the hepatitis B surface antigen is low. For phase 4 is known as hepatitis B surface antigen negative chronic hepatitis B. That's the old nomenclature, phase 4. In that phase 4, we have intermediate hepatitis B surface antigen. The E antigen is negative, the viral load is above 200, and then the liver function test, which is ALT, may be elevated. And phase 5 is resolve hepatitis infection. And then in that, the parameters all will be negative. The viral load will be undetectable. Then there will not be evidence of liver disease.
I think, of course, phase 5, for example, there are people who are actually on treatment or have had the disease acute stage and followed up.
Yes.
Until all these parameters.
The seroconverted.
Yes, become negative.
Yes.
Let's see. I think there's.
Oh, there are some questions.
Okay, let me see. Anonymous attendee is asking, on one of the tables you are using, please tell us the tables.
Tell us the labels.
The labels. Hepatitis B surface antigen.
Yes.
Hepatitis B surface antibody.
Yes.
The last is it hepatitis B core antigen or hepatitis C? Hepatitis B core antibody.
It's hepatitis B core antibody.
Okay.
Hepatitis B core antibody.
Second question here is, what will, from Anonymous again, what will be the management for a hepatitis B surface antigen positive in pregnancy?
In pregnancy. In pregnancy, yes.
We are going ahead of ourselves here.
Yes, because we're
getting there. So answer your question later when we get to the point. The third question you're asking, same person, please, hope we can get the slides later. Of course, we will do that. We'll send the slides to your email as soon as we're done. Okay. There's Christian Mwemeka here is asking, what's about the average cost implication of running a full panel test for a patient that tested positive to hepatitis B surface antigen? I think
it actually depends on the lab where.
It depends on where you're doing it.
Yes.
I don't have the figure off head right now for our center, but you can come and find out. I'm sure it's very moderate. In Limi Hospital Lab. Okay, you can come and find out there. I'm sure we have it's actually a moderate, it's moderately priced. There's another question here from Wenliu Ali. Do we commence breastfeeding a newborn before giving hepatitis B immunoglobulin? For a baby born to hepatitis B positive mother, it is advised that the baby should first of all be immunized before breastfeeding is commenced. And that is our practice. Okay. A lot of Anonymous also asked me, thanks for this presentation, sir. Please, can you explain the phase 5 of the nomenclature that is resolved hepatitis B?
Yes. So the simple idea is that once somebody is infected with the viral particle, okay, it can either progress from acute to chronic, as I said before, or it can resolve. That's the summary. Then the table that I presented earlier, there's what we call seroconversion. That's just a summary of that phase 5. That initially the person is infected, yes, and demonstrates the surface antigen in the serum. And then after some time, the immune system overwhelms the virus and clears the virus.
Correct.
At that stage, the person becomes negative.
Immunized from infection. So yes, the person is actually in phase 5.
In phase 5. When you do the other markers, liver function test is normal. There's no evidence of liver disease. And then the E antigen and the viral load is less than 10 international units per ml. That is phase 5. And in the old terminology, we call it hepatitis B surface antigen negative stroke anti
Hepatitis
B core antibody positive. That shows the person is immunized, just like my colleague was trying to say, from acquisition, not from vaccination. Any other questions to consider before we move on?
Okay. When Liu Ali is also asking again, what's the place of Pegasus?
Okay. We are getting down there gradually. A pegylated interferon, so to say.
We'll get there shortly.
We'll get there shortly.
Stay with us. Okay, anonymous attendee. What are the chances of a chronic hepatitis B patient seroconverting while on tenofovir?
The chances, we will consider that during the treatment.
Part of the treatment.
Yes.
So just stay with us and you get your answers.
All right. So these are some of the things to consider while you're managing somebody with hepatitis B. Of course, you look at the liver structure, do abdominal scan or CT scan. CT scan will be more informative, of course. And then specifically, you can do a fibro scan just to assess for fibrosis or cirrhosis, so to say. It's a non-invasive test. There's a specific probe for it. It's called fibroscan probe. It's a little bit more expensive than the ordinary scan. It gives us an information on the stiffness of the liver, and it has a grade, it is scored. So it's trying to just mimic liver biopsy, so to say. Yes, it's not invasive, without going into this. And to follow up to that, the simple way that have been developed to assess the level of fibrosis is using this simple formula called the APRE score. A means ALT, which stands for alanine aminotransferase. The value, usually we take the upper limit of it, which is ULN. The normal upper limit means ULN. It's AST, not ALT. I say ALT. It's AST that we use to assess that. We use the AST level. We divide it by the upper limit. Yes, that is why when people come, you always ask for full blood count. You're interested in the platelet counts. So once you get the platelet count, say 350, you slot it into this formula. You can download the app on your phone and use it. It's simple. You don't have to cram it. And then you multiply by 100. So once you have the result, you begin to compare it. The APRE score, which is aspartate transaminase platelet ratio index. That's the meaning of APRE. If the score is greater than 1.5 from this calculation, it shows significant fibrosis. If it ranges between 0.6 to 1.5, it shows you're trying to grade the fibrosis. That's the summary. Yes, degree of fibrosis. That's just the use of this formula. So it helps you also to add on to your fibroscan, yes, which is a non-invasive method, because doing liver biopsy these days have a lot of complications associated with this, and these have been found to be reliable. Okay, so this is the same thing as we have said earlier, the liver function test. So we are coming to indication for treatment. Acute viral hepatitis, straightforward, no treatment yet, except symptomatic support. Once somebody comes, no symptoms, and then you find the markers are positive, the liver function is normal, and then the IgM is positive, is in the IQ phase, no treatment. You don't bother yourself. But the recommendation is that supportive follow-up. That's what you do. But the chronically infected individuals, it is recommended that you treat them depending on the criteria I'm going to list out now. There are various algorithms that have been proposed. World Organization is available, which is the one we adopt in Nigeria. And then we have AASLD, which is American Association for the Study of Liver Disease. And then we have the European Association for the Study of Liver. And then we have the NICE criteria, which is the National Institute for Health and Clinical Excellence. Then we have also National Institute for Health Recommendations. These are the various algorithms that have been proposed to recommend for the treatment of chronic viral hepatitis. Using the World Health, since I say that's what we adopt in Nigeria for the treatment of chronic hepatitis B, what are the indicators? Mainly, you use three criteria: the viral load, the serum alanine transaminases, the severity of the disease. Severity, is it cirrhotic, decompensated cirrhosis, or is it PLCC, that's primary liver carcinoma, cancer. Yes. So these are the three combining criteria that you use as indicators for treatment as recommended by World Health Organization. You do the APRES score, as we said, to get evidence of cirrhosis, no matter the liver function and the hepatitis B. When it is evident, when it is greater than, when the score is greater than 2, as I've mentioned, is an evidence of cirrhosis. So you monitor and treat as such, or you send the patient to a center where they can take care of the patient properly, especially where they can do liver transplant. Chronically infected adult above 30 years with APRES score less than 2, and then with persistently abnormal ALT levels, and then the viral load is greater than 20,000 international units per mil, no matter the E antigen status, is a candidate for treatment. So the decision to treat is usually clear, especially for advanced liver disease and people with acute liver failure and cirrhosis. That one is straightforward, it's clear. Those who have cirrhotic decompensation, regardless of the level of the viral load and the alanine transaminases level, immediately you also refer such individual to a treatment center. For those with minimal fibrosis and low risk of progression from chronic hepatitis B, you don't consider treatment, but such people should be identified and you keep monitoring them with time. These are just the indicators. As you monitor the patient, you see these, you categorize them. And we have mentioned this earlier before. Those that you see, they have a E antibody positive, and then they have a viral load greater than 2,000 or 2,000 times 5.6, which is the copies per mil. And then they have less than upper limit of normal for alanine transference. You monitor them. There's no need to treat them. Inactive carriers, you also monitor them. Those with compensated, that means they have fibrosis, but yet the viral load is undetectable. According to European Association for the Study of Liver, this is their recommendation. You also monitor. Compensated cirrhosis with undetectable level and any level of ALT, you also monitor. For chronic hepatitis, those with chronic hepatitis, whose viral load is greater than 2,000 international units per mil, and with a liver function that is above the upper limit of normal, you treat. We are going to see the treatment modality in a short while. Those with chronic hepatitis and the E antigen is negative, those ones, when you do their viral load greater than 2,000, ALT greater than upper limit of normal, you treat. Those with hepatitis E envelope antigen positive with compensated cirrhosis and detectable, which is greater than the value we mentioned earlier of the viral load, not minding the level of the liver enzymes, you treat. Those who have compensated cirrhosis with detectable viral load, no matter the ALT level, and then the hepatitis E antigen negative, you also treat for that European recommendation. Now, for those that you have made up their mind and they are already on treatment, how do you monitor them? You do the 3 markers we mentioned: DNA, viral load, liver function, and serology. How often? Every 3 months until it becomes less than 300 or 200 as the case may be. Yes. And then you monitor them every 3 to 6 months thereafter and follow them up as such. Those that have ALT, every 3 months, that have ALT normalization, you follow them up as such too, every 3 months, once they are on the treatment. Those that have E antigen positive, you follow them until, as they are on the treatment, you follow them up until they become negative. Negativity and the presence of E
hepatitis B, E envelope antibody.
Yes. When they become positive for that, you follow them up with the surface marker every 12 months. And then for those that have surface antigen negative, once you sustained from the drugs that you're giving them, sustained enough suppression of the DNA of the virus, you follow them up every 12 months by doing hepatitis B surface antigen. These are the approved drugs. And the question now we ask, does it have a cure? Do we have a cure now? We'll answer this question as we're discussing now. These 2 questions will be addressed here.
Okay, we didn't answer.
Yeah. Now we have, these are the recommended first-line drugs for the treatment of hepatitis B, chronic hepatitis B. Once you have gotten the indication to start them on treatment: interferon, alpha, and then pegylated interferon, lamivudine, adefovir, and then entecavir, and tebudine, and the Fovir. These are the, yes, these are the drugs that are available for first-line treatment of hepatitis B. And then these days we begin to have what we call TAF. It's still the variant of the tenofovir, but it has another component that helps to fasten the absorption of the drug and the delivery of the active ingredient. They call it TAF. That's tenofovir aladenomide, something aladenomide, fumarate. We call it in short form TAF.
I think before we go, we should also let you know that the first 2 treatments are actually injections.
Yes, they are pre-filled drugs, injectables subcutaneously, and they are expensive, and they work through the immune system of the body. For you to use this drug for 48 weeks, you will have spent nothing less than 20,000 US dollars, 10,000 to 20,000 US dollars. If you, I can't remember the cost.
It's expensive.
It's expensive somehow. And that is why the directly acting antivirals are giving us the results with less side effects, and the cost is minimal, it's affordable. So that is why World Health Organization and other algorithms try to encourage, because they can give us, they can clear the virus and bring it to a non-detectable level, which we call functional cure. We have what we call functional cure and sterilized cure. Sterilized cure, you're able to uproot completely the viral particle. And that is our focus in the future. Drugs are under trials to uproot the viral particle completely. And we will see some of this. And that's why initially we asked the question, can we get a cure? These are the dosages of the drugs and how they are best given. And the
You go to the chat box, please. If you're raising your hand and ask the questions, go to the chat box. We'll answer your question as you ask them.
Please put up your question in the chat box. We will attend to them. So these are the dosages, the route of the various first-line drugs that we mentioned earlier. So as we send the slides to you, you can see them. As I said before, the interferons, either pegylated or non-pegylated interferons, their dosage, and then the duration, the route of administration, and then recommendation for the genotypes they are best for is stated in the table. But we have emphasized in the Limi Hospital, we use the tenofovir and we're getting our results. The reason being that tenofovir is very potent DAS with no resistance recorded. And that's why we adopt that as our first line treatment agent. Do you have any question in the chat box? None yet. Okay, I hope we're following.
Okay, anonymous again. Please, what is the most reliable indicator of fibrosis/cirrhosis between APRI score and abdominal ultrasound?
Abdominal ultrasound between the two. Well, there are a lot of factors. The skill of the person that is scanning also, yes, it's also important. So to compare them, this is a mathematical method that have been formulated and is giving us a very much reliable results, though not as reliable as liver biopsy. So the most reliable marker is, or method, is the liver biopsy. But since the liver biopsy is associated with, yes, invasive, has a lot of complications, and so on. All right. Any other question there?
Please, Adiza, just send your question to the chat box.
Yes, Adiza, I know you have been doing well. Remember to drop your question at the chat box. All right. Can you treat forever? That's the questions we want to ask ourselves at this point. Do you keep treating the person? Keep treating the person. So we want to look at the endpoints of therapy. When do you stop? You just keeping the person forever. There are markers.
That's a big question.
Yes. So we'll use this slide to look at that question. Any room for drug combination, lamivudine, and tenofovir? Yes, some people use combined agents, lamivudine, tenofovir, but resistance is very common with lamivudine, and the single agent is giving us the results. So why increase unless there are indications?
Sometimes with treatment failure, you might
Yes.
have to combine agents. And the advantage again of combining two agents at the same time is reduction in resistance to the drug. So of course, it's possible to combine when there are indications.
To combine in terms of resistance. But for tenofovir, no resistance have been recorded yet. The tablets that we talked about, that's the oral first-line drugs.
The tablets are readily available in our facility.
They are very, very much available. Very much available. And they are affordable. Yes. They are available and affordable. I can assure you that.
Well, the question Mr. Afedijo is asking, sorry if I mispronounced your name, I'm sorry. Considering our environment here in Nigeria, what regimen is affordable and effective for someone who has met criteria for treatment?
Very straightforward. We talked about resistance. We talked about costs. We talked about availability. These are some of the things we consider in our environment. We cannot compromise effectiveness of the drug to cost. So in the limit practice, what we do, since we know tenofovir is available, it can be patient centered in the sense that the patient can take the drug himself. It's patient friendly, it's pocket friendly again. So in our environment, especially in the living group of hospital, we have known and we have received satisfactory response from the use of the tenofovir. So that's what we recommend to most of our clients in our practice here.
It's effective, it's easily administered,
yes,
and it's affordable. Okay, so
and it has no recorded problem of resistance yet. So that's why we adopt the tenofovir agent. Next question.
So Christian Mwaemeka is asking, can there be seroconversion of the hepatitis B surface antigen after some duration of treatment?
Yes, that is what I have defined earlier. Functional cure. Functional cure is a situation where the person have undetected viral load, and then the phase 5, let me use that word, the phase 5. At that time, the person has seroconverted and the person is on treatment. After that, you follow up the person every 3 to 6 months.
Yes.
I don't know whether Mr. Christian got my point.
I'm sure I think he did.
All right. Thank you.
Thank you for your question.
So before the questions came up, we were on the issue of can we continue the treatment forever or how do we do it? There are criteria. The ideal endpoint and the intention is for us to achieve sustained hepatitis B surface disappearance. We used to clear it from the virus, from the blood or the body of the infected, with or without evidence of surface antibodies. After 6 months, you discontinue the treatment. Once you get sustained disappearance of the surface antibody, antigen, 6 months after that, you can discontinue the treatment. We consider that as intermediate good.
But before that, the patient has to be followed up.
Of course. Yes, the patient will be followed up continuously as recommended earlier, between 3 to 6 months. And then when an individual is E antibody positive. Our aim is for the person to sustain durable seroconversion to a state of E antigen negative, or maintained a suppressed viral load below 10,000 copies. Below 10,000 copies, with the disappearance of the surface antigen. We can suspend therapy at that point and follow up the person. That's our goal. That's our aim. And then there should be normalization of the liver function on one part. What if the person is E antigen, envelope antigen negative? What we consider our goal for that individual is to maintain a suppressed viral load below 10,000 copies, and the liver function should be normal. At this point, we can decide to suspend the therapy and follow up the person as recommended earlier. Undetected DNA 6 months post-therapy will sustain clearance of hepatitis B surface antigen, give us functional cure. That means there is no complete cure yet, but research and some candidate agents are in the stage of trial. And we'll mention some of them shortly. Any question from the chat box? None yet. All right.
Chinonso Emmanuel is asking, do you treat someone who tested positive for hepatitis B surface antigen but is negative to other
markers? The answer is no, because the other markers that would guide you to commence therapy are absent. The viral load, you're telling us here that the viral load is absent. So you cannot commence. The best option is for you, maybe this is at window stage, you monitor. Yes, follow up. That's the best approach. You follow up this kind of candidates. It's not good. All right. Final question for us. Can we cure hepatitis B? We have said not yet. We're not yet. But we're pursuing the nearest future. We can get a cure. Now the question is, why are we not having a cure? Why are we not having a cure? Remember the virology of how hepatitis B and HIV behaves. There's what we call covalently closed circular DNA. That is the particle or the material that the virus uses to manipulate the mechanism of the cell host. Yes. So once it enters, it covalently gets bonded with the infected cell. And most of it, yes,
enters into the nucleus of the cell and begins to direct the activity of the cell.
Correct.
So as soon as that happens, it takes over all the actions of the cell and makes it to produce more of its kind.
Yes, more of its kind.
Depriving the host cell its normal function.
Yes, it's normal physiology. Yes. It will take over the operations, complete operations of that particular cell, and then manipulate it. Now, most of these drugs that are coming up, these candidate agents that I mentioned, that are coming up, they are targeting that CCC DNA so as to stop that process or to knock off that process. When we're able to achieve that, then we can say we are at a point of sterilizing cure.
Because the position of the cccDNA,
yes,
is inside the host nucleus.
Yes.
It is difficult to reach it. And because we cannot reach it without destroying the cell,
yes,
we can only manage.
Yes.
We cannot have a cure yet.
Because if you want to do anything to that particular one, you have to destroy the entire cell.
Yes.
That means you're telling us that you want to destroy the entire liver.
Destroy the entire human being.
Of course, that's how it will progress. Okay, so work is still being done. Research is going on. Investigations, drugs are being tried at various levels to get to the root of this cccDNA relationship with the cell. Once we are able to achieve that, we'll say we have gotten a cure. And you can ask, why do we have a cure for hepatitis C? It's because hepatitis C does not have a reservoir like this particular virus and HIV.
Well, Mr. Dr. Andezi Abel Niputwe is asking, sorry if I mispronounced.
Andezi Abel Niputwe.
How do you treat hepatitis B,
C,
and C
co-infection, where both
infections
require treatment? It's simple. You know that hepatitis C have a cure. And then, yes, you can only control hepatitis B. Now is what we discussed earlier. There are indications for combination therapy. Once you do your serologic markers for hepatitis C or for hepatitis B, and you're able to genotype hepatitis C, genotype of C, you know the drug that is specific for which type. You now use a combination therapy, combine it with tenofovir, and you are suppressing the B, and then you're getting treatment for treating the C. So soposbuvir combined with tenofovir, for example.
Okay. So maybe I say last name. How do you? Okay, I think we just answered.
Yes, we just answered this
question.
It's the same question. Maybe he was trying to type it. All right. So this is where we are. Prevention, health education. Of course, those risk factors we mentioned earlier, we try to work on them once we have our guests or patients and their relatives come around. We health educate them against all of these practices that we mentioned. And then, of course, vaccination, whether active or passive. Okay, then we'll conclude at this junction by saying that majority of hepatitis B patients are unaware of their status because the disease is asymptomatic. We have mentioned this earlier. Okay, and the clinical cause and the natural progression of the disease from either acute infection to chronic or reactivated situation have been discussed earlier, unless if there are further clarification. If not, at this junction, we want to step down here and say thank you to all the participants. And then the next topic that will be taken up for this webinar shortly will be told us. And I want to tell all our participants that we are physicians in the Limi group of hospitals located here in Abuja. We have 3 branches called the cardio care that specialize in cardiac problems. And then we have the Limi group of hospitals also located in Wuse here in Abuja. And we have the multi-center hospital, which is located in Central area, where you find the gynecologists, the surgeons, the family physicians, and other services are available. And the dermatology too, residents in the multi-specialist center. So we encourage everybody to bring their relatives or come for screening of hepatitis B following today's lecture.
Okay, thank you everyone for being a part of this webinar. I hope you enjoyed yourselves, and I hope we answered all your questions correctly. Please join us next week, Wednesday, for another webinar as informative as this on neonatal cardiac lesions, bedside identification and care. So you are invited for another webinar as interesting as this, related to children this time around. Webinar on neonatal cardiac lesions, bedside identification and care. Your CME slides and YouTube links will be sent to you via your email address. Thank you once again, and goodbye.
Okay. Take time.